I feel like I need to do the introduction now. Should I just wheel into that? So we've just been chatting away here. I'm Terry Kuti of Deep Sea Foundation, by the way, and I'm going to introduce this lovely guest that I've been chatting with, who's been a friend for a little bit. But we're having these interviews today at the ARSA Summit in New Jersey. I flew over here from Seattle at the gracious invitation of ARSA, which is the Advanced Reconstructive Surgical Alliance. So I do want to thank them for providing this space for me. But my guest, who I'll introduce in a moment, is with the Premier Surgical Network of Surgeons, which is part of the ARSA Alliance. And so I'll have information where to find this lovely lady and the Premier Network of Surgical Alliance in the video. I'm going to introduce her now. Since we've been having our chat before, we had our dessert first.
Yes, scrumptious.
So I'm speaking to Dr. Anjeanette Brown, who I met, she can probably tell you the year.
2020.
At the BC3 conference put on by the wonderful Dr. David Song of Georgetown, who I haven't seen in a while, and I miss him. But she is certified by the American Board of Surgery with a special interest in breast health, and that's why we're talking to her today. You heard our lovely conversation. I have a script, and I have subsequently thrown it out the window because, like I said, we had our dessert first and spoke to her. But she's also a member of the prestigious American College of Surgeons, the Society of Surgical Oncology, and the American Society of Breast Surgeons. Now, I'm going to ask Dr. Brown a question in a moment because she served 4 years in the United States Navy.
I did.
Thank you, ma'am. And she served as a general medical officer on board a combat support ship of over 600 enlisted and naval officers. I'm going to ask her about that in a minute. She also served aboard the USNS Comfort.
I did.
A medical treatment facility activated to provide support during rescue operations in New York City following the attacks on September 11th, 2011. Now, why did I put all that into the introduction? Because I want to ask you, Dr. Brown, as a breast surgeon, you deal with your own colleagues, lots of personalities. You deal with breast cancer patients, lots of personalities. How did that experience in the Navy help prepare you for all of this?
Well, thanks for having me. And please call me AJ.
Okay, AJ.
So, fun fact, Dr. AJ Brown in the Navy sounds like a dude. So when I would walk in the room, they would go, oh. Now I'll go, yup, hi. Not what you expected. So having a crew complement of all the personalities, of all of, we call them the salty dogs, the men who have been on ships their whole naval career, never really dealt with women, especially women in authority, and now I'm the doc, and I'm the only doc. So if you want your fit rep done, which is how you get your promotions, I have to do the physical. So they would try to get around it by talking to my, what would be the equivalent of a PA, my doc, my chief. And I would say, well, one, no, doesn't work that way. I said, and two, you want my little fingers. You don't want this big sausage fingers, do you?
I have a higher comfort level.
Yes. So I will answer your question, but also funny story. So because of those interactions, much like surgery, you haze the people that you know will do the job. And the people that are slackers and worthless to you, you don't really even deal with. That's very much the surgical way. It's very much the military way. So on the ship, when it's such a tight community and you're stuck together and they can find you anywhere, even in the, we call it the head, but even in the toilet, you'll be trying to do your thing and people knocking on the, ma'am, can I talk to you? I'm like, my pants are down. Can you give me a second? Can you just give me 1 minute. You learn to deal with the people who have to deal with you, so they tolerate you. You deal with the people who just want to like live in your skin, and you're like, all right, I don't need another one of me. We're not Siamese twins. And then you have the majority of the people who are happy to have you there and appreciate your expertise, and they don't really bother you. And it's similar to medicine, because when you have breast cancer patients, you treat them like a delicate Fabergé egg. I mean, eggs are so expensive now, but like a Fabergé egg, they're just going through it right now.
Yeah.
So you give them all the grace that you can. And it's harder, really, for the support staff, hospital or military, because the support staff really get the brunt of the ugly side of the scared patient. Well, why can't I get in? Why can't I talk to her? They get all that. But when they come in, they get into my door and sit down, they're like, oh my God, I don't know. So this phenomenon happens, and I let them maybe do it once because they're scared. But if they continue to do it, I will call them out on it. And that's kind of the military thing too. Like I'll say, I know you're scared, but these ladies did nothing to you. So I'm not saying you have to apologize to them, but realize you sound a little much.
Yeah.
So you're giving them 22. You need like a 3. You need to give what you're giving me to them, because they're just getting their orders. So the military makes you realize not that it's not that serious, but the level of just anxiety, it does, I hope, help kind of bring it down for the patient. So when I have to tell them bad news, I do, give them the bitter, and then I give a little sweet. So the patient we were talking about earlier, she's 50, she's never had breast cancer before, it's triple negative. I didn't give her all that over the phone. I promised her I would call her. That's the pregame. I make sure that she knew, I'm going to call you. I didn't love it. Maybe I'm wrong. And I always put the self-deprecation in there, like, I hope I'm wrong, and I hope when I call you, you're like, ha, told you.
Yeah.
I hope you do that to me. But if not, this is what you can expect. And then when I give the call, it's a shock.
Yeah.
But then I always, you're going to see me for an hour or more in person. All the questions you need to ask, I'm going to break it down for you. The piece of paper that looks super scary with the big red ink, I'm going to put it in the pamphlet. I'm going to make it very clear. It'll be something you can go back to. So the military definitely helped me deal with people and their emotions and not take that on, because it's very easy to automatically respond to, you feel attacked because the patient's nervous, and it's easy to just be like, who are you talking to?
There's a word that comes to mind when you're talking, AJ, and it's emotional efficiency.
Oh, I like that.
Yeah.
Yeah.
I just came up with that listening to you.
Yeah, but it's true.
Yeah, it is, because I think sometimes I use the term dealing in drama. That does no patients any good. At the end of the day, they want facts.
Yes.
They want to know what the plan is.
Yes.
And that's kind of what you laid out.
Yes.
In your eloquent description of.
Yes.
Yeah.
So as many times as I think my military surgical approach, it's touchy-feely when it needs to be.
Yeah.
But I don't dumb it down. I'm not going to be like, oh, okay, but no.
Yeah.
No. I give them the facts.
Yeah.
But I'll tell them, you're going to survive this.
Yeah.
And every once in a while you do get one, but they know. You know, those ladies know when they come in and it's a fungating mass, and they're like, oh, something fell on me last week, and you just have to just
yeah.
I mean, you can easily be like, what the hell are you talking about? This has obviously been there.
Yeah.
Because I've had ladies come in where they've had, my older ladies, they'll have like a perfumed handkerchief. And then, so it's almost like a telltale sign. Like if I walk in and I'm hit with a bunch of perfume, I'm like, oh, someone's hiding in there.
Wow.
And they're still wearing their bra, even though they're supposed to be, shirt off, gown on.
Right.
I'm like, And then you just know. So I get on the ones that I know can handle it, and the ones that I know that they can't, I just let them tell their story, and I'll go, okay, well, I'm glad you're here now.
Yeah.
I don't need to berate you.
Yeah.
Because it's fungating. There's no nipple. There's crusty things coming out of your skin. I don't need to sit there and be like, where the hell you been? Like, where? Like, because that's not going to help.
I'm glad you're here. That's a good comment.
Yes.
I'm glad you're here now.
I'm glad you're here now.
It's like you're in the place you need to be.
Yes.
Yeah.
I'm like, I got you.
Yes.
You may not like what I have to say.
Yeah.
But I got you.
Yes, I got you. You're in the place you need to be. Can't say it any better.
Yeah.
I'm going to segue into BRCA patients if we can. What treatment options are available today?
So,
I mean, it's not always surgery.
It's not always surgery.
Right.
Because I have a few patients who are BRCA. I have one that's BRCA1 and one that's BRCA2, just I can think of off the top of my head, who chose not to go to surgery. Most patients are like, get them off.
Right.
Get them off. I call it the Roto-Rooter. Get them off, get it out, get the ovaries, the tubes, the uterus. I don't need it. I mean, that's your knee-jerk response.
Because the risk is so high.
Exactly.
And they know it's not if, it's when.
Exactly.
Yeah.
But there are some ladies that's not where their head's at. Most, I would say 100% eventually get there, but it's a very tightly scheduled surveillance, ultrasounds, I call them the feel-up appointments, the MRIs, the mammos, and I'll let them know, like, if we're watching this, we're watching this.
Yeah.
So don't come whining when I tell you it's time for the MRI. Don't bitch at me when I say, no, now it's time for the diagnostic mammogram that includes the ultrasound. I said, I don't want to hear it. This is what we signed up for.
And that's going to be twice a year, alternating.
Yes.
Yes. So, I mean, that imaging alone can be burdensome and a tipping point, I think, for some women to choose surgery.
Yes.
It's the mental anguish sometimes that they go through.
Yes.
So.
Yes.
Well, what about, the non-surgical options, is there any prescriptive or medication options that are being offered now? I'm just curious.
There are, and I would say the ones I'm most familiar with, because I always profess to my patients, I send you to medical oncology because they are the fabulous people with the big, giant, nerdy brains that love to be on top of all of the medications, immunotherapy, drawing your blood, sending you for your DEXA scans, bone density.
Yeah.
I was like, they love that crap. God bless them. God bless their big, nerdy brains.
Yeah.
I was like, I like to just kind of cut and go, yay, look what I did.
Yeah.
And then just follow
that's
you.
true. Yeah.
But if you have a patient who has a genetic mutation that is pathogenic, which means that you are at higher risk at some point in your life to getting breast cancer, because it's not just BRCA1, BRCA2. I mean, there's PALB2, there's CHEK2, there's ATM. There's a myriad of genetic mutations that can put you at risk. Our company, our group, does offer genetic testing, and there are panels that are just the basic BRCA panels.
Right.
There's the 40 gene panel that I like to offer. There's an 81 gene panel. I don't know all those genes, so I don't even want to dip my toe in that. But if I do the 40 gene panel, which I'm fairly familiar with, if you're an estrogen receptor positive patient, there are plenty of anti-estrogen medications that can actually just sustain you.
Yes.
And it might even reduce if you have a tumor, reduce the tumor burden. I have a lady I've been following for 10 years. She is a trooper. horrible ejection fraction. Her ejection fraction, which is for your heart, is in the high 20s, which is horrible.
Yeah.
No anesthesia. Doctor wants to touch her.
Ooh.
And she's been on anti-estrogen therapy for 10 years, and she's still with us. It's shrinking very slowly over time. And
Interesting.
but it hasn't gone anywhere.
Yeah.
So I just see her as maintenance.
Yeah.
And she's doing her thing. She's got some dementia. She's got some other vascular issues going on, but she's still chugging along.
Whew. Not the norm, but
Yeah.
Well, as we wrap up, I cannot help but ask you about your attire today. More specifically, the butterfly pin.
My butterfly. So my little floppy butterfly, Frances, is my mom's mom. She's not with us anymore. So I'll give you kind of an answer in a roundabout way. So
Go for it.
my mother's mom, so maternal grandmother, and her sister both had breast cancer. But postmenopausal breast cancer.
Okay.
So not the kind that I'd be worried, I need to do genetic testing.
More age related.
Probably. But my great grandmother had, now I'm 53, I'll be 54 in October. So in the 70s, Gen X, woo. So in the 70s, you were told to just go outside because it was adult business being spoken in the house, so just go play. And I remember my great grandmother had some kind of woman's cancer. It could have been uterine, it probably was ovarian. But I will never know because I was not there. And unless you're in the field, people don't get into the nitty-gritty.
Right.
So she passed away from whatever this female cancer was, and then her two daughters had breast. And then my grandmother, because of tamoxifen, wound up having uterine cancer. And her sister, Aunt Bertie, my great aunt, had a GIST tumor, which is a not uncommon stomach cancer.
Just never heard of that.
So something's going on there.
Yeah, I'd say so.
I should probably get genetically tested. You know how doctors are. I'm like, yeah, I should probably do that. If I was my patient, I'd be like, you dumb whore. Why have you not gotten genetically tested?
And you're thinking, I have a schedule to keep.
Yeah, and I also should get my blood work, but doctors are bad patients. But, so Frances, when she had her breast removed, because she just opted to get it removed, I very much remember it was a male surgeon, not that male surgeons are bad, but it was a general surgeon. This was late 80s, and he did a mastectomy. He closed her with staples, and I remember thinking, what is that? That looks crazy. Now, stapling, I've been in practice almost 17 years. I have stapled maybe 4 patients, maybe 5 in my whole career. Because aesthetically, if I was that patient, I would say, this looks like Frankenstein. But my grandmother, she was like, I don't care. And I said, So this was her pin. And because of her longevity, she lived to 92. Wow. She was 70 when she got the diagnosis, and she took the mastectomy. I was in med school because originally I thought I was going to be Audra McDonald. Love that woman, want to be that woman. I was a French minor and a music minor and a zoology major, so totally thought I was going to be that chick. And then my dad was like, do you want to eat? Do you want to have a life where you're not living with 3 other people? I was like, I can't do that. No, I can't. So then I pivoted, and I always liked science. And my dad was like, why don't you want to be a doctor? My mom's a nurse. My mom's an OR nurse.
Okay.
My grandmother, Frances, was a teacher, an educator, as she would say.
Yay, Frances.
Yes. So because of her, my worldview got opened up. She's the one that encouraged my parents to let me go and travel abroad when I was in college, and I did a semester in France. So je parle français because of her. And I did. I was at the l'École d'étrangère in Nice for a semester when I was a junior, and so her Live and Let Live, very Auntie Mame. Like, Auntie Mame is one of my favorite movies. The original with Rosalind Russell. Love that movie. There's a quote that says, "Life is a banquet, and most poor suckers starve to death." Absolutely true. Absolutely true.
After we get done, I'm writing that down, but go ahead.
Absolutely. So she had this pin, because she was a glamour gal. And when I was deciding what I wanted to do once I got to med school, I was either going to be a neurosurgeon, pediatric surgeon, because all that fine little detailed stuff, trauma surgeon, which is more my personality, like, shut up and let me cut you, or get out. And she said, "Why don't you think about breast?" And I was like, no. So I had said to my grandmother, "I can't deal with whiny women. I don't want to deal with emotions. It's just, no." Because I'd been already in the military at that point. So, yeah.
Oh, okay.
Yeah.
That was going to be my next question.
Yeah. So
She saw this.
Yeah.
She saw this.
So I'd done med school.
Yeah.
And then in between med school and residency, I did my general medical officer. Because I wanted to be taken seriously. If I'm going to do it, I'm going to do it. Most women at that time, if you're an officer in the military, Navy, you don't necessarily have to deploy. You can be at a hospital. And I was like, who's going to take me seriously if I don't do the do? So I said, I'm going to be assigned to a ship. Pay is great and underway. And then once I was there, I was just like, I need to get a SWO pin, Surface Warfare Officer pin. That shows that you learn the ship. Like, if it got down to me driving the boat, we're all effed.
We're going down.
We're going down.
Going into the drink.
Right. That's like the Department of Transportation being president as a lone survivor. It's like, that's not what you want. So
it's definitely not.
So when I was in residency, and she was like, "What kind of surgeon do you want to be?" And I was saying, "Well, neurosurgeon, pediatric surgeon, trauma surgeon." And she said, "Think about breasts." And I was like, "Oh, yeah." And then as I looked into it, I was like, I could do this. There's some artistry. There's some finesse. There's, it lets me do what I want to do. It gives you kind of I call this the family practice of surgeons, because we don't operate and let you go. We operate and keep you.
Yeah.
It's a testament to my patients, that the ones that don't need me anymore, not my cancer patients, but the ones who may have had breast pain or a cyst or some calcifications, after a year, I'm like, we're good.
Yeah.
And 9 times out of 10, they're like, no, I'm not going.
Peace of mind.
I'm staying.
I need to come back.
And I'm like, but you can always call me. You're not off the roster. You're just like second string. You're just like kind of waiting in the background. You're not like on the lineup.
Yeah.
And they're like, no.
Yeah.
No, I'm not going. But yes, so this is my little Frances butterfly pin. So yeah.
Well, she's been speaking to us the whole time we've been talking.
Yeah.
I love the way she flutters. When you connect with your patients like that.
I do, and I say you always need to have someone in the room.
Yeah.
And I will make them call someone.
Yeah.
And I said, you can have them on speakerphone. I said, but this is a lot of information I'm about to hand to you.
Yeah.
And you think I said, I get it. I'm that chick. I'm like, I got this. I said, I got it. But you're going to go home. And even though I wrote it all down for you, you're going to be like, what just happened? I don't know what's going on.
Yeah.
So a second set of ears. Now, you have those people who want to bring in like their whole tribe. And I'm like, no. One kind
Jumping in Aunt Tilly that wants to talk about her new barbecue recipe.
Yes, because that's what happens. Because if you bring more than one, it always gets sidetracked. And there's always that one outlier that starts kind of making it about them. And then you have to kind of shut it down, but not be a complete asshole. But you kind of have to be for the patient.
Yeah.
Yeah.
And don't you think sometimes too that telling them ahead of time, pick your caregiver wisely and prep them before you come, that they're your note taker and your second set of ears.
Yes.
And then you two can go out and have your coffee afterwards and talk.
Yes.
And decompress.
That's exactly what I say.
Yeah.
I said,
are you recording this? Good.
Absolutely. Every time. Because I say but I also say, on the flip side, everyone's an expert.
And everyone wants to share what they think you should do.
And everyone, especially because I'm in South Jersey. I'm South Jersey by Atlantic City. Mm-hmm. Philadelphia's close. Baltimore's close-ish. Mm-hmm. I mean, New York's not too far away. Mm-hmm. So I have 3 large metropolitan areas that, they can either go to Johns Hopkins mm-hmm. or they go up to UPenn, mm-hmm. Fox Chase, Jeff, or they'll say, oh, I'm going to go to MSK. I'm like, and that's, yes. Mm-hmm. I'm going to give you my talk. Mm-hmm. If you need the second opinion, I don't have a problem with it. Because I know what I'm saying is correct, and I know what I'm saying is for your benefit. Mm-hmm. I said, but if you have that little, devil on your shoulder, does she know what the hell she's talking about? Please go talk to someone else.
Yes. And
if you feel your journey needs to be with that other person, it's okay.
Yeah.
Please don't ignore the calls from my office and ghost me. We're just making sure you have somebody.
Yeah.
Because ladies don't like confrontation.
Yes. I love that process because sometimes that second opinion mm-hmm. only validates what you just said. They're going to go and find out the same thing and they're like, oh, okay.
Right. And why schlep all the way 2.5 hours from South Jersey up here, over an hour to Philadelphia, even Fox Chase. Fox Chase is really out of the way. Mm-hmm. When it's kind of up and then kind of over and in. Yeah. But I want them to know that I'm confident in what I'm saying. Mm-hmm. So by all means, most of the time it's not the patient. It's those other people who are like, and I said, if you want to quiet the Greek chorus behind you, if you need to go, because you've got the folks, you should probably not be in South Jersey because, they're just,
why are you going there? Or mm-hmm. why are you, Mm-hmm. Mm-hmm. Too many whys.
Yeah, too many whys. But I said, if you're not comfortable with what I'm saying, you're not going to take the guidance I'm giving you. So I need you to be comfortable with what I'm saying. So that's why I give them that. It's actually winds up being over an hour. Yeah. And then I always call them, like today, mm-hmm. I call it the pregame. Mm-hmm. I'm giving you the heads up. It starts at the biopsy because 99% of the time I know it's an issue. Yeah. So as we're doing it and it's super bloody or it's a little crunchy, I'll say, so I'm not loving how this feels, but then I'll give a positive. I don't love how this feels, but it's small. It's small.
Yeah.
So I don't see any nodes. Mm-hmm. So no matter what this is, fat necrosis, atypia, even if it's cancer, I don't see nodes. And I said, and we are so de-escalating that axilla now. I said, so if I don't feel it and I don't see it by ultrasound, because I'm ultrasound certified, and I'll tell them, me looking at it is like a radiologist looking at it.
Yeah, I didn't know that.
Darling.
Another skill.
Darling. So there's 2 pools.
That's so cool, though.
But there's 2 pools of fellowship-trained breast surgeons. So, there's 3 pools. So there's the pool of general surgery, also do breast. So that's pool number 1. They tend not to do the extra ultrasound certification, stereotactic certification. That's fine. Medical oncology tends to run that circus.
Yeah.
Then you get the next pool. So the next pool of people are surgical oncologists that are like their specialty is breast. So they kind of take it on, but still medical oncology runs that circus. And then there's us. So the fellowship trained people, I am the QB. I'm running all the plays. And even when my surgical stuff is done, I'm still in the back seat. And I'm still like, no, is that what we're doing? Okay. And that's how the fellowship trained folks, we operate. We have you forever. We have you forever. Twice. So operate week after, month after, and then every 6 months for the next 5. And then after that 5, it's yearly.
Wow.
So that's how we do it. And then in that, there's a subdivision. Those that are hospital-based, they don't get the certification for ultrasound biopsies or for stereotactic because of the downstream revenue the hospital-owned doctor brings to that platform. So they don't do that stuff because the radiologist takes it. But when you're private, I take it because I can get you in, I can explain it.
I was going to segue to the private sector. So that's the benefit for you.
Yes.
And the patient.
Yes, because I can wiggle you in. I don't have to wait on, the radiologist who went to Tuscany for 2 weeks and they're the only ones that do breast
Yeah.
And then you kind of get pushed off. I can say, you know what? I don't need a lunch. You can just come in. And then it never fails. I love my patients. They bring me such cool shit. They bring me food. They bring me clothing. They bring me jewelry. They bring me mugs. One lady brought me a brown boob. It looks like an acorn. It looks like an acorn, but it's a little brown boob. So if I have it sitting up on, it's got a little smiley face and the little brown areola in the nipple. So when you see it, it looks like an acorn. But then when I take it down and I go, no, look, and then people are like, oh my God, that's so cool. So yeah, she sits up on my shelf in my office.
Dr. Brown.
Yes.
Thank you.
You're so
AJ,
welcome. Yes.
Thank you for joining me again for the friendship that we have had over the past few years and for your lovely story.
Well, thank you for having me.
Absolutely.
I feel like Delicious Dish, on Saturday Night Live. Have you ever seen that? The sweaty balls?
Oh, yeah. Well, when I speak into my microphone, I like to talk like that.
And I do too. I find it to be very soothing if we talk.